So now I'll talk about hemothorax. So instead of air collecting within that pleural space, now all of a sudden we have blood collecting there. Pre-hospital treatment, there's not a whole lot we can do. We're not going to be able to control the bleeding. We just need a rapid transport. They have to go into surgery. You can also have air and blood at the same time. So now you have a hemopneumothorax. Um, there's still not a whole lot we can do for that. So here's the representation. Oh, my bad. Um, I'm not sure why the top one is highlighted, but you have a hemopneumo on the bottom because you've got air at the top and liquid at the base, blood at the base. If you lay them down, now all of a sudden you're going to affect the entirety of the pleural space with the blood. So keeping them set up is best. True full hemothorax, they're going to have some issues. However, when it's just the blood, once you get to the point of that space being filled, it doesn't continue to expand over with pressure. Like it will stop bleeding at some point because it just can't take any more pressure. Air will continue to force things over into the mediastinum. So, um, truthfully, better to have a full out hemo than a full out pneumo or a hemopneumo, if you have to have one of the three. Cardiac tamponade definitely is more common with penetrating trauma. So what happens is the heart is damaged to the point where that protective membrane over top of it doesn't allow the blood that's leaking to go anywhere. So now instead of air compressing a lung, you have fluid compressing the heart, which obviously not a great thing. Once that pressure starts building up to a certain extent, the heart can no longer adequately actually pump blood out. For pre-hospital treatment, a lot of it is just going to be supporting ventilation, providing rapid transport. They're actually going to have to go through a process called a pericardiocentesis, where they stick a large needle into that pericardial sac and start evacuating all of that blood. But yeah, that's something that has to be done in the ED. We're not doing that in the field. Rib fracture, those are pretty common, particularly in older people that already are dealing with bones that are relatively brittle. The fracture of one of the upper four ribs is actually considered more of a significant MOI, excuse me, because those four ribs are much more closely attached within the sternum. There's not a lot of cartilage. They're shorter, smaller overall in their diameter. And so they actually have to take pretty significant compression in order for that to break one of those ribs. A fractured rib, besides just being super painful, may end up puncturing the surface of the lung, causing a pneumothorax, can lead to a tension pneumothorax. You can have a hemothorax or a pneumohemothorax. So ribs, while you're not breaking this massive bone, people tend to think rib fractures are not serious. It's certainly not true. If you have a condition called a flail chest, you have a full segment of the chest that basically becomes detached from the rest of the thoracic cage. That's where you get that paradoxical movement. So that section that's broken no longer has structure and goes back and forth. Really, the paradoxical motion is going to be more of a late sign and definitely occurs with more significant fractures. For pre-hospital treatment, really all we're going to do is maintain the airway, provide respiratory support if needed. We can give them supplemental oxygen. We may have to positive pressure ventilate them because they're not going to be able to take that deep breath because of pain. So we may have to breathe for them to make sure they're getting adequate tidal volume. What we used to do is pack that area that was flailing with a bulky dressing and then wrap really tight around the chest. We don't do that anymore. So if somebody tells you to do that, they may have been in the field for quite some time. Current protocols say that We allow the patient to self-splint because naturally they will pull their arm in and kind of hold that area themselves to relieve some of that pressure. Other than that, we are not bulky dressing, nothing. Other chest injuries, pulmonary contusion. If a patient has a flailed chest, they're more than likely going to have a pulmonary contusion too. So we just kind of say that those go hand in hand. What happens? The pulmonary alveoli are damaged and become filled with blood, which then lead to the patient being hypoxic because that oxygen is not going to diffuse through the liquid and then across the membrane. It just doesn't happen. Provide supplemental oxygen, positive pressure as needed to make sure the patient is getting enough air in. Other fractures, you can have a sternal fracture. That requires a significant amount of force, a lot. If you have that much force applied to the sternum that it actually breaks, something underneath is going to be injured as well, just without a doubt. You can have clavicle fractures, broken collarbones. You can have significant damage or disruption to a very large bundle of nerves. And then you do have a central vein that runs right there as well, your subclavian vein. Beneath that, you have your subclavian artery. I mean, there's some major blood vessels there too. We typically don't think that they're going to be a huge issue, but definitely can be as well. You definitely want to keep an eye out for pneumothorax development. That clavicle runs basically over top of the first rib as you're feeling down your rib cage. The first one that you count is actually your clavicle because that first one is truly down underneath of there. Traumatic asphyxia. I don't know if this picture is coming through really well for you guys, but there's a significant color difference from clavicle up versus clavicle down. So what happens is you end up having a sudden compression of the chest, which makes the pressure go sky high super quick. So you actually force all of the blood out of the chest and typically up into the head. So you get distended neck veins from the pressure of that blood rushing up. You get cyanosis in the face and neck. You get hemorrhage into the sclera because of all that significant pressure. And you tend to get a discoloration of the head and neck while the chest goes a little more pale than normal. This obviously is going to be something that's severely detrimental to your patient. You're going to probably have underlying injury to the heart, possibly a pulmonary contusion. Really, we're going to provide ventilatory support and monitor vital signs during immediate transport. There's not a whole lot we can do for this out in the field. Consideration of ALS, because we've talked about compression injuries. This is a massive compression injury. So if they can't be freed quickly, you're going to need to get ALS on scene before you end up freeing them. Blunt myocardial injury. So this is blunt trauma to the heart itself, which will make it extremely hard to maintain adequate blood pressure because that muscle is damaged. You want to suspect this in all cases of severe blunt injury to the chest. Your pre-hospital treatment is monitor the patient's pulse very carefully, note any changes in blood pressure, and provide supplemental O2 while you transport immediately. Commotio cordis. So this is a chest injury because of a sudden direct blow that occurs at a critical point in the person's heartbeat or their cardiac cycle. And so it sends the person into immediate cardiac arrest. So like people that have taken a baseball to the chest or bull riders that fall off and go into sudden cardiac arrest, maybe because of this. So you actually have a heart rhythm called ventricular fibrillation that ends up occurring, and it responds very favorably to defibrillation, especially within the first 2 minutes after the injury. This is very commonly associated with sports-related injuries, but anytime that a patient sustains trauma to the chest and is unconscious and unresponsive, you should have this at least go through the back of your mind. Laceration of those great vessels may be accompanied by massive and rapidly fatal hemorrhage. Pre-hospital treatment, CPR as best as you can, ventilatory support, immediate transport, and monitor for shock and changes in vital signs. Oftentimes, there's not a whole lot we can do for somebody that has a massive laceration. But if it's just kind of leaking, if you transport rapidly, they may have a shot. So, biggest thing, don't spend time on scene. Grab the patient and go. This is it for chapter 29.